Okay, so nice to meet everyone. My name is Ornia, and I am the organizer for the first year revision sessions. And today, I'm going to do a lecture on blood. Now, this is a topic in your organization of the body section. Um, so we're going to start off with, if I can get it to move. There we go. So, starting off at the beginning. So, blood cells originate from a common multipotent stem cell known as the hematopoietic stem cell, or you can sometimes see it in textbooks as HSC. So, during early development, this hematopoiesis can occur in distinct stages. First of all, when we're very, very young, we can have it in the yolk sac, in the AGM region, and later in the fetal liver. However, in adults, we then lose that ability and the process takes place in the bone marrow. So these HSCs have the ability to self-renew and they ensure that there's a continuous supply of stem cells whilst allowing us to differentiate to have specialized blood cell types. The difference, as we can see on this graph, hang on, just let me is we have the myeloid line and we have the lymphoid line, and these then make their specific blood cell types. So for the lymphoid progenitor, we can see on this diagram that we have NK cells, and then we have the area where it goes into T cells and B cells. Whereas if we're looking at the myeloid progenitor line, we can have erythrocytes, mast cells, myeloblasts, and so on. So if we're looking for, say if you were in an essay, why is this relevant? So these HSCs are responsible for maintaining blood cell production throughout life, but that means that they can be vulnerable to damage. So in cases like when people are having to have radiotherapy, or people are having cytotoxic drugs, for example, in chemotherapy, this can cause damage to the HSCs and can lead to conditions such as leukemia and where the blood cell production can become really uncontrolled. So, if you're wanting to think of somewhere to link for your essays, that might be a good little clinical link. So, starting off easy. So let's have a look at red blood cells. So red blood cells or erythrocytes, you can see it as both, make up about 40% of the total blood volume and play a crucial role in oxygen transport. And they're around 6 to 8 micrometers in diameter. Now, the key thing about them is that they have this biconcave discoid shape. And that means it can maximize its surface area so it can be more efficient for oxygen exchange and for carbon dioxide exchange. And they're also full of hemoglobin, they lack a nucleus and mitochondria to ensure maximum oxygen carrying capacity. They're also easily deformable, and this means that they can squeeze through tiny capillaries without breaking. But this also means that it's quite difficult, again, if you want a clinical essay link, that it can be, we find it very hard to find an artificial substitute for blood because of this nature, that it has like an elastic nature where it can squeeze through the tiny capillaries and kind of stretch and recoil when stress is applied. And another clinical point is that this is what is altered in SCA, so sickle cell anemia. I'm sure you've all heard of it. And so this is where there is a mutation in the globin gene, which leads to the production of an abnormal form of hemoglobin, which we call HbS. And under conditions such as low oxygen or high acidity, the red blood cells become rigid and sickle shaped, and these can cause like clogging of the vessels, and it can restrict the blood flow and can cause episodes of severe pain, and these are sometimes called sickle cell crises. So, let's talk about erythropoiesis. So this is just the production of red blood cells, as we can see here. There are some really key nutrients that are required for the proliferation and differentiation of erythroblasts. So these are vitamin B12 and folate, and these are things that are commonly tested on, blood tests when you're in primary care. And a deficiency in these vitamins can lead to impaired erythropoiesis and can result in something called macrocytic anemia. And this is where the red blood cells become abnormally large. You can also have a deficiency in iron, which is also required for the production of hemoglobin. And this can lead to the opposite, called microcytic anemia, where the cells are smaller than normal and less efficient at carrying oxygen. So, our body regulates erythropoiesis through EPO. And this is a hormone that is released by the kidneys and the liver in response to hypoxia. So, what that means is when the oxygen levels drop, or whether that be due to reduced red blood cells, or if there's lower oxygen available, or there's an increased oxygen demand by tissues, EPO signals the red bone marrow to produce more red blood cells so that you can increase your oxygen carrying capacity in the blood. And again, if we're wanting to link it to the clinical setting, sometimes in the hospital we have to give exogenous EPO to patients. For example, if they have kidney failure and so they cannot produce it themselves, just to help them stimulate red blood cell production. So, how is it metabolized? So, the lifespan of a red blood cell is approximately 120 days. And what happens is they once it's reached those 120 days, they are recognized and removed by macrophages in the spleen. And during this process, the globin proteins are degraded, the iron is released, and it's recycled for future blood cell production. And the heme component is converted to bilirubin, as you can see on this graph here. So bilirubin is then transported to the liver, bound to albumin, where it undergoes conjugation so it can become water soluble. And that is then how we excrete it from our body as it passes through urine, feces, and bile. And again, you can have conditions where this red blood cell breakdown is damaged, such as in hemolysis, and it can mean that you increase your levels of unconjugated bilirubin, so you can't get rid of it, and it can result in a condition called jaundice, and can cause yellowing of the skin and yellowing of the eyes. So we're going to now go through all of the different cells that make up our blood. But this is something that's really important to just know off the top of your head because it can quite easily come up in MCQs and they're really easy marks. So let's start with our neutrophils. So neutrophils are the most abundant white blood cell, and they make up 40 to 70% of the total white blood cell population. And so they ingest, kill, and digest microorganisms, particularly bacteria. They're also responsible for the formation of pus at infection sites. That's also a very classic question. So they have a characteristic multilobulated nucleus. I've got kind of a diagram of it, but we'll go through some MCQs later where we'll see what it looks like under the microscope, just to make sure that we can identify it. And so, yeah, going back to the how it fights against bacteria, their numbers increase in acute bacterial infection in particular. And they also play a role in inflammation. So they adhere to the vascular endothelium and migrate into tissues at sites of infection or injury. And this is guided by the chemotactic factors to allow them to know where they need to go. So again, notice how I've really put the emphasis on that bacteria. These are really key in bacteria. Another common MCQ question is they will show you kind of a blood cell count, and it will ask you what kind of infection is most likely to be occurring here. So if you see a really high neutrophil count, try and think of bacterial infection. So next we have eosinophils. And eosinophils make up around 2 to 4% of all white blood cells, and they play a key role in the immune response. And their primary function is the killing of parasitic infections such as hookworm. But they're also really important in allergic reactions and asthma. And if we look at the image again, if it's under the microscope with some H&E staining, you can see kind of a bilobed nucleus. Um, yeah, so move on to basophils. So basophils are the rarest type of white blood cell, and they only make up 1% of the total white blood cell count, and they're rarely seen in peripheral blood. So under the microscope, they are basophilic, which means that they stain a dark purple with H&E staining because they're packed. It's trying to show it in this diagram here, is they're packed with granules that contain important vasoactive substances. For example, histamine, which increases blood flow and vascular permeability, and also proteolytic enzymes such as elastase, which help break down tissue components. So they play a key role in inflammatory reactions, particularly those involved in acute allergic responses and a parasitic infection. And they also have IgE receptors, which means they are involved in allergy and hypersensitivity reactions, similar to mast cells. So then we have monocytes. So monocytes are a type of white blood cell that circulate in the bloodstream in an inactive state, sorry. And after this, they migrate into tissues and differentiate into mature macrophages. And macrophages, as we know, have a wide variety of functions, such as they phagocytose and kill microorganisms to clear infections. They ingest apoptic cells to prevent kind of harmful debris building up. And they also remove damaged tissues so they can secrete enzymes like collagenases to help tissue repair, help with remodeling, and with homeostasis. Um, and in terms of its appearance, they are the largest white blood cells and they have a distinct kidney bean shaped nucleus. Um, and say here at the last point, it's say numbers increase in chronic inflammatory conditions. So in chronic conditions such as rheumatoid arthritis or kind of long-term cardiovascular disease, you can see an increase in monocytes. So it's just kind of highlighting that they're more in the long-term immune response. Then we go on to lymphocytes. Now, there's not that much detail that is required for you guys in first year. You will learn a lot more in detail when it comes to pathology in second year, but these are the key players in the adaptive immune system. So they are from the lymphoid line, which I explained right at the beginning. So we have B cells, which mature in the bone marrow, think B for B, and then T cells that mature in the thymus. And so what happens is lymphocytes encounter antigens on antigen presenting cells in secondary lymphoid organs. Now, secondary lymphoid organs, that's just a group of it's just a word to kind of describe where the different locations are. So these could be lymph nodes, these could be in the spleen, and these could also be Peyer's patches, which are found in the gut. And what happens is these interactions then trigger the immune response and lead to lymphocyte proliferation. And they also have very large nucleus and yes. So we now know about all of the cell types, but we want to learn about the kind of key functions of the blood. So one of the key functions is clotting. So What happens when we have a vascular injury? The body has kind of some coordinated events to prevent excessive blood loss and also to try and ensure the vessel can be repaired as quickly as possible. So I think we can break it down into four kind of actions. So, number one, the initial response. So, there is an injury to an artery, and that triggers local smooth muscle contraction and vasospasm. And so that means we can reduce the blood flow, reduce the pressure at the injury site to try and prevent any further blood loss. That is when primary hemostasis begins. Here, platelets will begin to adhere to the damaged endothelium and form a little plug, as you can see in this diagram here, a platelet plug to temporarily seal the wound. Then secondary hemostasis is all about stabilizing the clot. And so we have a coagulation cascade, which I will talk about in a couple of slides, which causes the formation of fibrin strands to reinforce this plug, creating a stable clot, as we can see right at the end. And then what we want to do is try and repair. So we will have clot breakdown and vessel repair. So once healing begins, the clot is gradually degraded by fibrinolysis so that normal blood flow can be restored without excessive clotting. And so this is the cycle that happens every time we have some form of vascular injury. So I mentioned platelets a lot there. So platelets are the key component in primary hemostasis. And these are small cell fragments that can be produced by megakaryocytes in the bone marrow. And so they adhere to the endothelium upon injury. And this is triggered by glycoprotein receptor interactions with ligands like von Willebrand's factor and collagen. And once these are then activated, they can then aggregate to form a plug and they release granules containing factors like serotonin, ADP, which allows further vasoconstriction and further aggregation, and clotting factors. Then we have secondary hemostasis, so I'm just going to talk about this in a little bit more detail. So, as I said before, secondary hemostasis is kind of the stabilization of the platelet plug. And this is enabled by polymerization of soluble fibrinogen into insoluble fibrin strands. And this kind of acts as a glue that holds the clot together. And this is all facilitated by an amplification cascade, which is controlled and is dependent on vitamin K. So as we can see in this diagram, we have the intrinsic pathway and we have the extrinsic pathway, and they both converge onto the common pathway. So the extrinsic pathway is triggered by tissue damage. And with tissue damage, there are things that are released, such as tissue factor and factor 7, which starts that cascade. So that's the extrinsic pathway. And then with the intrinsic pathway, this is triggered by contact with abnormal surfaces. And another clinical link is that there is a condition called hemophilia, which is a bleeding disorder, and that can happen when there is deficiencies in factor 8 and 9, which are really important in the intrinsic pathway. But eventually, both of these then converge onto the common pathway and result in thrombin activation, which converts fibrinogen into fibrin, as I said, to solidify the clot. go back a second. And then final thing I wanted to talk about on this part is just the idea of the clot removal to preventing excessive clotting, which I mentioned as the kind of fourth part of the pathway. So once healing has started, the clot is broken down by plasmin to prevent unwanted embolism formation. And this is regulated by inhibitory factors like alpha 1 antitrypsin to ensure that clotting is controlled. So that is kind of all I'm going to say about hemostasis. Now we're going to move on to antibodies. So antibodies, immunoglobulins, that's, they can be referred to as both again in your textbooks if some people are finding that confusing. But they are specialized proteins which are produced by plasma cells. And these are released at specific sites. So we have GALT, which is the gut-associated lymphoid tissue, the mammary glands, the lymphoid organs, which are things like the lymph nodes and the spleen, and also the bone marrow. So this is where they are synthesized. And the antibodies are, as we can see in this diagram, they're composed of 4 polypeptide chains. So we have 2 heavy chains and 2 light chains, which are held together by disulfide bonds for stability. And they have 2 functionally distinct regions. So we have the Fab region, which is here at the top in the diagram, and Fab just means fragment antigen binding. And it's formed by the variable domain and the first constant domain, and they are responsible for binding to the antigens with high specificity. And then we have the FC region, which is the fragment crystallizable, and it's essential for immune system activation. And so it's involved in complement activation, opsonization, mast cell degranulation. So we have some really key roles of antibodies that we want to know about. So why do we have antibodies? So first of all, we have it for agglutination, keyword, agglutination and precipitation. And what that means is basically clumps all of the antigens together to make them easier for phagocytes to clear them. Then we have neutralization. So the antibodies can also block the pathogens and toxins from interacting with the host cells. And this is really important, specifically in viruses, because it can prevent them from binding to and infecting cells. Then we have opsonization. Now, opsonization is the process where we kind of tag pathogens. It's almost as a little alert saying, yes, we want this to be destroyed by phagocytes and macrophages and neutrophils. Then we have complement activation. So antibodies trigger the complement cascade. We'll talk about that in a couple of slides' time. So they're really important in the MAC formation. And then finally, in degranulation. So antibodies can bind to receptors on mast cells and NK cells to trigger that activation so that we can have all the releases that we talked about before, such as histamines and inflammatory mediators. And the NK cells recognize antibody-coated infected cells and induce cell death. So, what antibodies do we have? So, there are 5 classes of antibodies: IgM, IgA, IgG, IgD, and IgE. Now, I think this table is all of the information that you need. It's pretty self-explanatory. These slides will be available so you can copy it down in your own time, but it's really easy for them to ask little questions, and we'll see that with the MCQ, so you go through later. So then we have complement. So what what is complement? I remember when I first heard about it, I was kind of confused because there's all of these letters and numbers to know. But I think the key thing is to just understand that the complement basically just amplifies what can be a very small immune response into a larger and more effective immune reaction. So it's just a network of neural proteinases which are secreted by the liver and also by macrophages sometimes. So we can see it in this diagram here. And what the complement pathway does, it leads to the formation of C3 convertase, as we can see here. And what happens is C3 is cleaved into C3A and C3B, and C3B then combines with C3 convertase to form C5 convertase, and it can make these key things, which are C5A and C5B. So C5A is an anaphylatoxin, and that recruits and activates immune cells more so that we can increase our response to the pathogen. And then C5b, C6, C7, C8, and C9 form this thing called the membrane attack complex, or MAC. And what this is it punches holes into bacterial membranes and allows lysis to happen. Then we also have C3 and C4, which are more opsonins, and what they do is again coat the pathogen and enhance phagocytosis. So I think the really important ones to know are these that are on the left here. So C5a, that is an anaphylatoxin, C5b, 6, 7, 8, 9 for MAC, and C3 and C4 for opsonization. These are the key things that the complement cascade creates so that we can have more effective immune reaction. Now, there are three ways which we can activate the complement pathways. So we have the classical pathway, which is activated by IgG or IgM when they're bound to an antigen. So just as it was in the slide before. Then we also have the MBL lectin pathway, which is triggered when mannose binding lectin binds to mannose on bacterial surfaces. And then we have the alternative pathway, which is activated by spontaneous C3 cleavage, allowing C3b to bind directly to microbial surfaces. Okay, so what we've done now, we'll just have a little bit of a recap of everything so we know what we need to know. So this is the general overview. We want to understand what a HSC is and how it kind of goes into two lines. We have our myeloid line and we have our lymphoid line, and there are the specific cells which are made in these lines. Then we have all of the individual cell components. So we have our red blood cells. We talked about how red blood cells are formed and how they are metabolized. Then we have the other components. And again, like I said, this is a really easy thing for them to test you on. It's just a quick 1 second note at the back of your head, and you can feel relaxed that you've got a couple of points in the bag. So we went through neutrophils, we went through eosinophils, we went through basophils, monocytes and macrophages, lymphocytes. And then we spoke about the importance of what happens when there's an injury in our vessels and how we work to try and repair. So we have clotting. We went through primary hemostasis and platelets, secondary hemostasis, then what antibodies are, and our antibody classes and our complement. So what we're going to do now is I have 16 multiple choice questions. Now, I wouldn't say blood is a particularly complex topic. I think, throughout medical school, there will be other concepts which are harder to get your head round. A lot of the things with blood is just fact learning. So, but with that, they're really easy points for you to get. So what we're going to do is we've got 16 multiple choice questions and we are going to go through them all. So I have all of them on the slides. So the first question is platelets and erythrocytes are derived from, so this is going back to the very first slide, what line do they come from? Is it the myeloid line or is it the lymphoid line? Does anybody fancy saying it on the microphone? Does anybody know? Okay, let's see if I can see it in the chat. So the answer to the first one is myeloid. Now, when you go back through the slides, that's just the answer has come there from the very first diagram, which is a nice, easy one. Okay, so what blood cells account for 20 to 40% of all white blood cells? Give you a couple seconds to think about it. We can, yeah, so lymphocytes. What blood cells account for less than 1% of all white blood cells? A. See, I've not thought this through. I've done a lot of them with A. So, but sometimes, I've been there and I've sat in exams and I'm thinking, gosh, I've put A lot of times in a row, but always go with your gut. Don't try and overthink those kind of things. But yes, A, basophils. So neutrophils, are they derived from megakaryocytes? Do they usually form 40 to 70% of all leukocytes? Do they become tissue mast cells or are they multinuclear? On these ones, I think a good technique is if they have statements, is to just go through process of elimination. There will always be, two that you can get rid of, two that you're thinking, oh, it could maybe be one of those two, but just do process of elimination to give you some confidence. So yes, you guys were right. Well done. B. So they usually form 40 to 70% of all leukocytes. So another one. What's our fact about eosinophils? Do they A, kill multicellular parasites? Do they become tissue macrophages? Do they generate tissue macrophages? Or are they, a bit of a typo there, but are they derived from megakaryocytes? Yeah. You're doing really well, guys. Yeah. A, kill multicellular parasites. Well done. So macrophages. What's our fact about macrophages? Do they circulate in the bloodstream? Are they most important in acute infection? Are they most important in tissue remodeling? Or are they important in allergy and asthma? So C, most important in tissue remodeling. Um, would it be helpful? Do people understand that? Do people remember when I was talking about that, or should I go back to that slide? Um, mm. Basically, what happens with macrophages is that, as I said, they have lots of functions. So they're involved in phagocytosis and killing the microorganisms. They're also ingest apoptotic cells, but they also remove damaged tissue. So they secrete enzymes like collagenases, which can aid in tissue repair, but also remodel tissues. So that was the hint from before. Okay, now we're getting on to identifying under microscopes. So, does anybody know what these are? But the hint here is that the darker purple color is really dominating the cell. So that means it is a lymphocyte. If we think back to the diagram I showed before, where we are talking about the B and T cells, the image you have, it really is dominating the cell. So what's this one? What can we see here? It's it's again very full, but instead of it being kind of a solid fill, can you see here that there's lots of kind of little circles that kind of make everything up, the really dark purple color? What do we think that could be? These are basophils. So this is because they're packed with granules. So all of those little things, it's all the granules that are wanting to be released, such as our histamine and things like that, in response to this inflammatory reaction. So that's the hint to remember basophils. So what cells are these? What's the key thing about the nucleus within? Yeah, well done, guys. You're doing really well. So these are neutrophils, and the hint here is that they are multi-lobed, the nucleus. If you can kind of see they're kind of connected. They've got these big lobes, and that's really characteristic for the neutrophils. Okay, now we're back to our statements, and this is where I started talking about clotting. Try and picture that diagram that was on the left. So, what does primary hemostasis involve? Is it smooth muscle contraction and vasospasm? Is it the cleavage of fibrinogen into fibrin by thrombin? Is it for clot fibrinolysis? Or is it for formation of the platelet plug? But think about the four stages again. What did I say they were? Yeah, well done, guys. Really good. Formation of the platelet plug. If you have these kind of images in your head, it's a lot easier, in exam times to if you can picture that. Okay. Which coagulation pathway involves these factors and is defective in hemophilia? Again, sorry, it was a typo. Um, and hemophilia was when I said there was the kind of clotting bleeding disorder. So again, a good way to link it to clinical if it's for an essay. Is it the extrinsic or is it the intrinsic? So B, intrinsic. Which antibody class forms the majority of serum antibodies? So this is just from the table that I explained. And that's IgG. You think about it, that's kind of the one that I think is it's what we most commonly talk about. And it's also what's quite commonly can be tested for. Okay, which antibody class is pentameric? Pentameric just means that it's kind of characterized by having 5 subunits, so pentagon. And if you can kind of picture that in your brain, if you can kind of picture what it looks like, and so that is IgM. So this is now going on to the cascade. And I said there's some kind of key ones that we need to remember. And that is the ones for the anaphylatoxin, the ones for the MAC complex, and one for the opsonization. So which one was C5? Yes, well done, guys. C, really good. Okay, what is the function of C4? Same again.
I have a quick question.
Yes.
What is an anaphylaxotoxin?
It's a very good question. Um, so it's just a very small peptide. So when this kind of the C followed by the number, these are peptides and they're generated from this activation. And all they do is again just specifically activate in more of an inflammatory response. So kind of I don't really think anything else is required in any more detail, but it causes activation of neutrophils, it causes activation of macrophages and just increases the inflammation. I don't know if that makes sense. Because the MAC complex is for the lysis, opsonization is for, the tagging and everything that we spoke about before, and that is more just of a general inflammatory mediator. Does that answer your question?
Yeah, thank you.
It's okay. So what is C4? So C4, opsonization of the pathogens. Okay. Which complement pathway is activated by the antigen antibody complexes? Now, I spoke about them only very briefly at the end. So these are the 3 pathways. So the classical pathway, the MBL-lectin, and the alternative pathway. And the answer is classical. So this is when IgG or IgM is bound to an antigen. So that is what we call an antigen antibody complex. So I think sometimes, you can be a bit intimidated. What does antigen antibody complex mean? But if we just break down what that is saying, it's saying antigen. We all know what an antigen is. Antibody, I said that it was IgG and IgM, so it's when they're binding together, and that is what activates the classical pathway. And kind of think classical, that's what we all kind of think of, back from A levels or when we're at school, that's kind of what we think of for the activation of the immune system. Okay, guys, that was all of the questions. You all did really well. If you scan this QR code, I will email the slides over to all of you. And if anyone has any questions, please do let me know. But I think a lot of this, as I said before, with blood is quite self-explanatory and it's not too hard conceptually. It's just a lot of kind of new words that you need to remember, and it's kind of the buzzwords. And it's really good foundations for, when it comes to clinical relevance of if we have deficiencies in these areas or if we have errors in these areas, why we can't fight off the infections. Okay, so I will stop the recording.